Good morning, judges. The topic of my presentation is role of risk loci FOXO genes in modulating the clinical course and susceptibility of type 2 diabetes in geriatric population. Human aging is a complex process. Biological aging may be defined as the progressive event-dependent decline in the ability to maintain biochemical or physiological function. In fact, type 2 diabetes, a disease of glucose homeostasis, can be conceptualized as a form of accelerated aging, as aging and diabetes are intimately related at a molecular level. The FOXO gene transcription factors, mainly FOXO1 and FOXO3, have broad tissue-specific functions linking gene expression to environmental stress, including glucose depletion, hypoxia, oxidative stress, and DNA damage. FOXOs mediate the effects of insulin on the expression of genes that affect glucose metabolism and cholesterol metabolism in the following factors. The loss of FOXO1 in the liver and mice leads to impaired glycogenolysis and glyconeogenesis, which suggest an important role of FOXO1 to regulate glucose production. Therefore, we have designed our study to determine possible role of SNPs present in FOXO genes in the risk of T2DM in geriatric population. Study hypothesis: aging and diabetes interplay role in pathophysiology of each other. Genes related to both aging and diabetes might play critical role in pathogenesis of diabetes with aging. Aim to find out the role of genetic variants of aging and longevity associated genes FOXO1 and FOXO3 with risk of type 2 diabetes and modulation of susceptibility with gene and risk factor interaction in elderly population of northern India. Objective: association of FOXO1 and FOXO3 gene polymorphisms with risk of type 2 diabetes in case control study in geriatric population. Association of genotypes with clinical biochemical parameters and aging biomarkers in the elderly North Indian population. Study design: it's an age-sex match 1:1 case control study. Study site: Department of Pharmacology in collaboration with Department of Geriatric Medicine, King George's Medical University, Lucknow. Sample size was 257. Group A was elderly diabetic control and Group B was control elderly healthy volunteers. Inclusion criteria: subjects with age more than 60. All the patients attending the OPTs and ward with type 2 diabetes and written informed consent was given with them. Exclusion: subjects less than 60 on insulin therapy, having liver and renal disease, having respiratory disease, etc. All subjects entered the study after they had given the written informed consent. Physical examination: blood pressure, body mass index, mini mental status examination was done, and lab investigation: fasting, lipid profile, fasting plasma, HbA1c, insulin, serum CRP, IL-6, TNF alpha level. FOXO 1 and 3 gene polymorphism by Tachman allelic discrimination assay. Ethical clearance was already taken from the ethical committee of KGMU Lucknow. Data height, clinical parameters: height, weight, and blood pressure were measured as per the WHO. Blood samples were collected from the subjects after overnight fast. 5 ml of the blood sample was drawn from each patient. HbA1c was estimated by HPLC related kits. Serum insulin, IL-6 were measured by Biorad ELISA plate reader. Homo IR was done, Homo beta was done. DNA was extracted from peripheral blood lymphocytes. Genotyping of SNP RS225310 was performed by Tachman allelic discrimination assay. Data was summarized as mean plus mean SD. The case and control were compared with the unpaired student test or ANOVA. The test for Heidi-Weinberg equilibrium and comparison of genotype and allele frequencies in the case controls were performed by chi-square test, and p-value more than 0.05 was statistically significant. Results: the age and gender distribution was comparable between case and control. The BMI, SBP, DBP, FPG, HbA1c, triglyceride, Homo IR, IL-6, CNP, and TNF alpha was significantly higher in case as compared to control, while the MMSE and HOMA-B were significantly higher in control against case group. This is the table. You can see the p-values of BMI, SBP, DBP, FPG, HbA1c. They are all statistically significant. Insulin resistance and beta cell function: fasting insulin was significant. HOMA IR, HOMA-B, and inflammatory markers were also statistically significant. Genotype and allele frequency distribution: statistical analysis of genotype and genotypic and allelic frequencies for the tested SNPs revealed no significant difference between T2DM and controls. Now here the table, we can clearly see that the values are non-significant. Again the values are non-significant. The genotype frequencies were in accordance with the Hardy-Weinberg equilibrium in the type 2 diabetes group as well as in the control group. Effect: the statistical analysis showed that there is no association between RS225310 genotype and risk of T2DM in elderly North Indian population. Effect of genotype on type 2 diabetes mellitus risk, all the p-values were not statistically non-significant. There was no significant difference in age, BMI, SBP, DBP between genotype groups of T2DM patients. There was no significant difference in lipid profile, FPG, HB1C between genotype groups of T2DM. There was no significant difference in fasting serum insulin level, HOMA-IR, HOMA-B between genotype groups and T2DM patients. No significant difference in HSCRP, TNF alpha and IL-6 between genotype and genotype of T2DM. Conclusion, the C and G alleles were the major and minor allele respectively in both elderly T2DM patients and healthy control. Study shows that is no association between longevity linked RS2253310 of FOXO3 and risk of T2DM. The genotypic and allelic frequencies for this particular RS2253310 revealed no significant difference between T2DM patients and controls. The genotype subgroup did not show any significant difference in glycemic status, BP, BMI, lipid profile. So FOXO3 may be acted by different mechanism in pathogenesis of diabetes. That's all.
Okay, it's a nice study. Why did you exclude patients on insulin?
Actually, it was done on the OHA especially because insulin, the adherence towards insulin is much better as compared to OHS. So we thought to just for the OHS we should just carry out the study. So excluded the insulin patients.
Don't you think that excluding patients on insulin is affecting the outcome of this study?
Surely, sir, because the sample size is not much. So I'm in the process also to go for the further study because it was funded by me only. So I am trying to just with the other collaborations, I should perform the study in a broad manner so that I can get the good significant values. And of course, at that insulin will be added. Then patients on insulin, yeah.
What is the cost of doing the FOXO1 genetic study?
So total, I think I had crossed 6 to 7 lakhs approximately.
Okay. So did you come across any other study in North India where they looked into the similar kind of a FOXO1 and FOXO3 genes and especially the transcription factors? Not only North India, whole India?
Maybe I have not searched much, but I've just, my guide just told that we should do in a gene manner. Okay. So just design something and we can do for that. So that's why.
What is the clinical relevance of this study now?
There is no such clinical difference because this is a very too much high cost factors and study. So it can't be performed for the clinical way.
Because sometimes when we do some kind of research, some kind of novel research, it should be replicable,
yeah,
scalable also. So when you do this kind of studies, especially the genetic markers and look into the transcription factors and its association, and now we are in the era of precision medicine.
Precision medicine, yeah.
So because doing these kind of studies definitely help in improving the care, ultimate care.
Yes, sir. But again, gene itself is a very costly matter. So no, all the patients can't, all the researchers or all the, it can't be bared by everyone. And it's not applicable for the clinical way because you can't, कोई भी patient आया हमने उसका ये करना शुरू कर दिया in clinic, it's not easy. So that's why.
Just few basic questions. How did you define your cases? Can we have the slide please again? Tech team. Just want to know how did you select your cases and your controls?
Okay, so it was randomly done.
Definition of your case in your study.
Case, so they were diabetic patients. Case, elderly because
about 60 years you mentioned. Yeah.
Coming in the geriatric medicine OPD and in the medicine OPD.
And what were your inclusion and exclusion for your cases?
Inclusion were the type 2 diabetic patients above 60 years of age, and the patients who have given the written informed consent for the study.
Duration of diabetes, any control? What have you looked at?
So duration was mostly 5 years above. It was not, I have not written,
just a minute. Tech team, can we have the slides back? For the same presentation, can we have the slides? Yeah. So this polymorphism was seen in how many of percentage of your cases? Your slides back. Just on the case, inclusion and exclusion.
Yeah.
So you've just taken patients more than 60 years.
Yeah.
That's it. And no, you have not mentioned anything regarding their BMI. How did you select, or did you disqualify them? Nothing like that.
Sir, obviously the patient who are diabetic, the BMI will be obviously above 23, above 25, and the patients were obese, or not obese, but in a slightly higher note after having diabetes for the past more than 5 years. The patients, they were not naive, no naive patients. They were all more than 5 years.
Okay. And only type 2 diabetic?
Only type 2 diabetic.
Were included.
Yeah.
What about the mutations, what you found in your cases, the percentage, and those you have not found within the cases? Was there any difference between the case with the mutation, without the mutation?
Yeah, no, because the sample size was very low, very less. So it was not very significant values were not.
Something patients you have taken?
The 257 patients were there.
That's huge.
So, but there was no significant difference in age, BMI, SBP and DBP between genotype groups of T2DM patients. No significant difference. The value will be significant if I would have taken more than 1000, then some significant result would be revealed. But in this few
This
patients.
is cases versus cases.
Yeah.
Right?
Case control. There was no significant difference in lipid profile also, FPG, HbA1c between genotype groups of T2DM patients. No significant difference in fasting serum insulin level, HOMA IR, HOMA B between genotype groups of T2DM patients.
Okay. Thank you.
What prompted you to take up this? I mean, as Dr. Aniket rightly prompted, this is a good thing from the research point of view, but whatever research we are doing ultimately is to translate it into clinical practice and see how it can improve the outcomes and care for the patient.
Yeah.
And in a typical Indian setting, especially in the rural settings, I think this will not be practically feasible to do. And when it comes to the relevance, how relevant do you think it is to our practice?
It is not, I can say that it is not relevant to the practice, but it is much more feasible for research.
Yeah.
Because what we practice comes from research. Every day, every minute, we are in the process of research. We are just researching something. We are adding our knowledge. So in this point of view, I know it is very much costly.
Yeah.
I have bared the cost, so I know its cost. But still, not everything is for the clinical. कि मैं clinic पे बैठा हूँ और मेरा clinical का काम हो जाए. तो clinical के उससे ही तो हमने लिया है.
But this cannot be used in the day-to-day practice.
हाँ,
as well.
no,
Yeah.
it can't be used. Thank you so much.